back to health and wellness. It's all about the state of maternal health in this country. And we're asking, where did we go wrong? How can we improve? What are those gaps that we can actually dissect on this show today? And that really is our question of the day to you. What do you feel are some of the gaps that are plaguing our maternal health care systems? A conversation that, of course, was, can I use the word, inspired more or less by the incident that happened of a woman giving birth on a tarmac road right outside Pumwani Maternity Hospital. It's good to point out, though, that the incident did not happen because the woman was not registered with Linda Mama. It was simply because of a nurse's strike. Remember what they said? That she was barred from accessing the facility due to a nurse's strike. And that brings me to my next point as I engage Lillian Mutua, who is a County Health Promotion Coordinator with NMS, as well as Dr. Simon Kigondu, gynecologist, here with us today. So this probably is really the biggest issue. Is this what we call the elephant in the room, right? People, or at least health workers, are striking, especially during COVID. If you look at what, for example, Kenya National Union of Nurses SecGen Seth Panyako has always been saying all along. He lists them so well while he's talking on the news. No masks, no risk allowance, no isolation facility. And so far, 10 health workers have died from COVID. And most importantly, delayed salaries. I'm going to start off with you, Lillian, on this. From a perspective from NMS, how is this situation being handled, by the way, with healthcare workers from, your desk? From NMS, I'm glad that our Director General Badi and our Director of Health, Dr. Kibaru, have engaged the union or representatives from NMS for the health workers, and they came up with a return to formula, and people are back on duty. However, I know it has been a big struggle within the system, not only for Nairobi, but across the country, where the healthcare fraternity feel they are not appreciated for the much they do. And especially one aspect that we'd really, as a health promotion officer, what I'd really like to engage the public with, as much as you are a health worker, or provider, it also drains you mentally and at times physically. You'll find that maybe something has happened to a client or a patient that you're handling. It's time for you to go home. You cannot really let and go home. You will still be there for that person, work with them until you see that everything has been stabilized. During the COVID-19 situation, we've seen spouses being rebuked by their partners because they are working, they are going on duty while they know that COVID is real. And especially when they hear that, because you will not miss to mention, and it will not be missed to mention, that maybe, like for example, in Nairobi, maybe we've lost a health worker, or we have some health workers who turn positive, then there's a disagreement between you and the family, whether you should go back to work or not. At times it even becomes physical. From the overstretching and the scenario for the COVID-19, everybody was anxious, everybody had stress levels. Maybe within your family, your partner has been laid off work. So it also comes with a bit of mental and psychological issues. Yet there were no structures ready-made for that, to handle that. Until maybe, like in NMS, we had to bring up these psychosocial issues and a department to engage with mental health issues. So there's so much that surrounds the health worker. Also our flexi time for our working hours. I think it also goes with the long hours that we are working with, and also the environment. So it has to be addressed from different issues. And just like Dr. was saying, we wish that when people are engaging about health workers and the situation and maybe their salaries, and I wish they were also listening from inside out. Because most of the time, you find that it's governance and policy that is deciding about it. But the real people are not asked, what would you like? Because just like Dr. said, in Moranga, they own the system. They give the shots. They tell them what they need to do. There's that good engagement. So I wish it could be all over. And we really you do want to call out to any health worker who's actually watching this show, or even related to a health worker, you know the sacrifices that they make. Why don't you call in and talk to us as well? Daktari, we understand that this actually puts a health worker between a rock and a hard place, but here's the big question. Is it ethical for medical doctors or, you know, the staff, so to speak, to strike just like everyone else in any other field, you know, withdrawing that treatment and healthcare to patients who, of course, you have a duty to protect their health and their life. And I know this will be a tough one for you because you are a medic, but at the same time.
We have addressed that thing. We launched a very effective industrial action in 2017.
Hold that thought. Purity is on the line, Doctor. Sorry to stop you there. Purity, good morning.
Good morning, Chico. My contribution is actually I'm in support of Dr. Kigondu. He has actually treated me some time back, and I'm so thankful. I am in support of his thoughts in that whoever circulated that maybe didn't know, but I was thinking of the mother's privacy, whoever was giving birth. My issue is the women sometimes are not aware of what they should do or not do. You find that, sorry to say this, but women sometimes matters so can be ignorant. So we need to equip ourselves, and now that we have the county government, and we have a department that is fully operational and in charge of women at the grassroots level. Thank you. Hi, Dr. Simon. you treated me. Thank you.
Purity, thank you.
All right. I don't, do you know, okay, I'm sure you
I know
probably
many Purities. I don't know
I know. Thank you, Purity, for that. But anyway, back to your point before we even pick up on what she actually mentioned. So yes, you're talking about, you know, where health workers are at this particular point.
Yeah. So if you Google YouTube, you'll find the prayer by the Embu doctors who are in their 4th month of non-payment.
Yeah.
So you tell me how someone who has not been paid for 4 months can treat you and why they should not go on strike. He's dying. You know, you're talking as if the health worker is not a human being. He's like a superhuman who can operate
24 hours,
Secondly, a lot of the times when health workers go on an industrial action is to save the public. Save the public. And I'll give you a very simple example that I often use to illustrate. Suppose you have 2 hospitals, a private hospital and a public hospital. And in both, the doctors are there. And the patient comes, and both the doctors prescribes that so that you do not die, you need drug X. You get? So they prescribe. So the one in the public hospital is admitted, but there is no drug X for whatever reason, and dies. The one in the private hospital, let's say, gets drug X, admitted for a short while, goes home. What will the public say killed that patient?
The doctor.
Yes. That's the point. So, assuming this doctor, because there is no drug X, goes on strike, will the patient survive? He will. He'll go to the public facilities, like, you know, watafanya harambe na vitu kama hizo, given the correct material and survive. Are you getting? So this strike has actually saved this patient. So that goes to the ethics of patient. There's something called moral injury. See, so you have a health worker who we are trained to treat, but after some time you realize the problems, you cannot sort out the problems of this, and there is someone else who is in control of funds, for instance, who is the one, so you go on strike. So you must really critically look at outcomes rather than the fact. So a politician will, when you withdraw, he'll say, look, they're dying, people are not being treated because the doctors or the nurse or whoever has gone on strike. You get the point.
I get
so it's a deeper issue and a deeper conversation.
You know, Dr. Thuranira obviously is my very good friend, and unfortunately he wouldn't even be part of this show, but he has been a very vocal individual as far as healthcare, the welfare of healthcare workers is concerned. What are you really predicting will go forward for the next couple of days should, for example, Kenyatta National Hospital goes on strike?
Again, we go back to the pillars of a healthcare system. And there's a leadership aspect. Now, for so long, health workers have asked for what is called a Health Service Commission, which would organize labor and enable Kenya be Kenya, whereby if I'm a doctor, I'm working in this county for some time, my wife is transferred to somewhere else, I don't need to quit this county to go there. I can be transferred and someone else brought and the services continue.
Yeah.
There is a group of people called Salaries and Remuneration Commission, who we recommended that they stopped knowing what they are doing. They were formed for two very reasons.
Yes.
To set
the
salaries of state.
Yeah.
To set the salary of state officers.
Right.
And recommend the salaries of other public officers.
Right.
Unfortunately, the Salaries and Remuneration Committee started setting the salaries of public officers, but suggesting the salaries of state officers. So it's a commission whose time got finished in 2014, and they are the cause of all the strikes from 2017 to today's Kenyatta. So Salaries and Remuneration Commission have decided, put upon themselves the idea that they are the ones who determine what clinical allowances are. So Kenyatta is on strike today. So from today, they expect that Nairobi Health will collapse as a result of Kenyatta going on strike. Kenyatta has been taking the go-slows from Pumwani and other grounds. So it's been cushioning. But now the Salaries and Remuneration Commission has decided their dues are not payable. So they're on strike from 9 o'clock today. It was actually supposed to be midnight. They pushed it a bit following discussions. They did not agree yesterday. So the best thing to do is to dissolve Salaries and Remuneration Commission, establish a Health Service Commission, so that we have workers who are working and not people who sit in offices to decide what their time is up.
Their time
SRC.
is up. Okay, and it seems like, of course, health workers are not going to back down at this particular time because you've been through a lot. Listening to what even Joshua had said earlier on, that he does know a health worker or someone an entrepreneur who is running a facility, and they haven't, received their reimbursement from NHIF for 4 good years. What's it going to take, in your opinion, Lillian, obviously as a health promotion officer, to get the big players to come together? What are your recommendations as far as that is concerned? Because as the elephants are fighting, the grass is suffering. So SRC, health workers, NMS, all the major players coming together. We are just asking a question: when will they sit down?
Well, right now we are all under devolution into counties. And to me, the best approach is for each county first to go back to the drawing board, have a desk review, see where they are having gaps, either in the structure for management, whether it is human resource for health, whether it's equipping our facilities, whether it's maybe building new facilities, maybe giving the services closer to Mwananchi, and then from there pick a discussion. And when we look at the ratio of the different cadres of healthcare providers according to the population, this has not been addressed well. Let us look at what are the recommendations from WHO and try to match up this. I know it's not easy to bring so many people on board on employment, but then we've also seen that people have retired, people have died, and there are no replacements made. Then the other day I was just looking at a department, and you find that in the next 5 years, most of them are going to retire. Is it the time that we are going to bring other new people on board? Because we also need succession management, we need induction, we need maybe training on the skills according to the environment where one is. We should also leverage on the community to identify its priorities, to identify what their needs are, what their available resources are, and then from there we match up together. Both the governors, the policy makers, the stakeholders, and at any given time, let us look at the community, that consumer, as the biggest fraction of the consumer and the stakeholder. Because if the community is not there, we do not even need the service. So the service is not because its duty to deliver the service. The service is there because there's someone to consume it. If there's nobody to consume it, then it is well done. For Nairobi, through the NMS, we have seen that we have identified sites where we are even going to put up temporary structures where people can go for level 2. That is the essential services which are given at the dispensary level. And we are also trying to offload our referral centers. The common person should also understand. If I'm just taking an example, you will not walk all the way from Embakasi to go and seek a service maybe at Mama Lucy or at Bagathi or Kenyatta. Go to the nearest facility, let them handle. Even if we are saying, and for Nairobi for quite a period of time, now we are having the essential drugs with us. And we are also having an emergency and referral system. So if we are not able to handle you at that point, then you are referred to the next facility. And it's not at your cost.
All right, I understand we've got some feedback, Lillian and Doc. Let's just take a look at what Kenyans are saying before we get back very quickly to this discussion. One says, hi Shiko, health is something that should carefully be taken care of. The issue with maternal health for our mothers and ladies needs more technology. I'm sure the Jubilee government had earlier allowed women to have a free maternal delivery. They should restructure and put more efforts in that side. All the machinery needs to be provided. The government should join hands with the doctors and nurses that then allocating funds to county government. I think it is best for national government to do its thing directly with the health sector rather than allocating the funds to the county government. You've gotten a serious nod from Dr. Simon there. Maternal care is worsening in government hospitals. The workers do well in referral to their private-owned hospitals. Okay. Hi, team. Sometimes it's not health workers' problems, but the systems. Health workers going for 1 year without salary, like in Vihiga County. Yet our government is very comfortable. Vitu kwa ground, need different.
Correct.
It is. It truly is. Lillian, even just looking at what had happened, obviously at Pumwani, we did see the apology that was issued by NMS. But here you have women representatives who did not take that lightly and said, we are digressing from the issue by saying, oh, it's the security guards who should be replaced. But it's really the health workers' welfare that needs to be addressed so that they can stop turning mothers away. So
I think at times, just like Daktari said earlier, we are quick to act. And for such babies who are born maybe just before they get to the facility or out of the facility, we call them babies born before arrival to the facility. It happens. I remember I've done 2 deliveries in the streets of Nairobi. In fact, one was captured, and I even tried to mobilize the people around to go to the chemist that was next by to get me a surgical blade and gloves and cotton, and nobody, the chemist people were not ready to do that until I called a traffic policeman who was coming by to go and pick that for me. The second issue is, as citizens, how prepared are we? Because a mother could deliver anywhere, even right in front of the gate at your offices. What will happen? How adequate are we equipped as adults with the skills of delivering babies?
And what about
at times, labor
services?
will even come in. When it is only you and your spouse, what are you going to do? Some people have what we call the precipitate labor. The baby just pops out. Will then spouse start yelling or running for their neighbor? You should deliver that baby. So there's a lot of life skills, what we are calling life skills in school right now, which should be given to people. And in the olden days, I remember my grandmother telling me she delivered a baby herself while in the farm. How did she manage to do that? So when we are looking at the healthcare services, are we also looking at the emergencies that can happen out of the normal? So and if they happen, what happens? And I'm very happy with one of the persons who wrote a message and said people should be educated during their antenatal visits, even before you get pregnant. And getting a pregnancy should not be taken as something light. In fact, going through a series of sessions by the time you think that I want to get a baby, you should get some lessons in between. You should get some counseling.
Yeah.
You should get some mentorship by the doctor or the midwife, and then walk along that line up to the last thing. Then we also have the 719, which is an emergency response number during this time of COVID.
Yeah.
I even would wish if the person who was at the gate that was not was not allowing the mother to access, the community that was around
could have dialed that number.
Yes, and there would be quick action.
Okay.
Then even at maternity at Pumwani,
yes,
the maternity wing or the labor ward is not next to the gate. So we look at different aspects. And when there's that yelling and shouting, and you also remember that people are on strike, you could also be afraid for yourself because you don't know what the commotion is, unless a trusted person comes and tells you.
Okay. It's interesting that you said that. Let me just share something. This is research done many years ago, but perhaps we're probably still seeing the same thing today. This was done by the Population Studies and Research Institute. Director Lawrence Ikamari, at the time, in a maternal health dialogue series, actually said that though nearly 90% of women in rural Kenya seek antenatal care, according to their research, many actually wait until the second or third trimester, limiting the benefits that they would even get, perhaps from even some of these health schemes. So do you think that trend is still continuing, Daktari and Lillian, where there are women who literally are not taking their antenatal clinics quite seriously, or for whatever reason it is? And please speak to the women about, you know, some of the dangers that could arise with you waiting till the third trimester and not getting the knowledge that you know. So this is where public participation and community participation comes in. Yeah.
So with development, we start seeing that maybe coming to for antenatal care, or as someone actually correctly put it, prenatal care is important, and that's where health promotion comes in, to educate people before they conceive. And secondly, you must also provide everything possible to enable someone to actually do what you're telling them. A lot of times you blame the women, yet the environment that they have been provided for is not available. For instance, an antenatal care clinic may be expensive. So if someone is poor, whether they are pregnant or not, they may not be able to access, and therefore you need to address the access factors. In maternal care, we say there are 3 delays. There is the first delay, the second delay, and the third delay. The first delay is at the community level. And one example would be, is the mother able to afford that health facility? That's a delay, meaning that if she's not able to afford, she has no access to that. The second delay is the delay between the community where she is to the hospital. Things like transport, what she was talking about in terms of the ambulance could not reach that place. You see, so that's a delay that can cause a problem. If a mother starts bleeding and is in a village where they cannot get, or curfew has been imposed and they cannot come out before 6 o'clock, that's second delay. Then the third delay is within the facility. When they go to hospital, are there qualified health workers? Is there equipment? Are they able to delay? You get. So you need to assess across those levels for you to be able to answer. There is no single answer. So different mothers would have different reasons for their delay. A lot of mothers would say, sini mutoto tu. I mean, they have delivered before. You get. So why you what is this to justify that? There was nothing happened. You see. But the idea is that every pregnancy is different, and you do not know what problems may occur. So it's just a rough assessment, and they had initially put it at a minimum of 4. The first statement, because at different levels of the pregnancy, you can detect different problems and intervene early. 85% of the deliveries will go on without any issues. Those 15%, you do not know who they are. And that's the only reason people go for antenatal care.
We literally have 1 minute, so I just want to wrap up by asking for you specifically, Daktari, things that we as the public need to point out when we are seeking some of these services, so that I even know the kind of facility I'm going to. We did have another gynecologist here, Dr. Kibe, who always talks about how women never ask questions when it comes to his practice. You know, you just go into a facility blindly. What can you advise women in terms of knowing where you're going, what to expect, so that you can actually have higher chances of a safer delivery?
So I think there are two ways. There is the women need to seek information. And nowadays there are many things. There is internet. So seek information on whatever condition. Then you also, the health workers and health promotion teams need to educate the community. And there you can come up with whatever, because everyone has individual issues that are different. So when you seek information from your side and the health workers provide information, then we are good to go.
Okay. All right. So can I say thank you so much for making time for us today. Lillian Mutua, who is joining us from the Nairobi Metropolitan Services today, as well as gynecologist Dr. Simon Kigondu, as we talk about the state of maternal health in Kenya. Of course, there's so much more that we can discuss, and still we can see your recommendations towards the government still streaming in through our social media platforms. I know Lillian has taken quite a number of pointers that she will be sharing with her colleagues today in the office. But we want to thank you as well for your feedback on the same. If this conversation was, of course, helpful, why don't you let us know at K24 TV is how you can reach us, and that WhatsApp number at the bottom of your screen. On behalf of the entire breakfast crew, my guests, and of course myself, Shiko Kaitani, asante sana. Have a blessed day. The Daily Brief is up next. Bye-bye.